So Mark Cuban has been posting some really lit content on LinkedIn lately. And his post yesterday about the audit limitations. Start over. Some people said they couldn't hear. Hopefully the audio is fixed now. So Mark Cuban has been posting some really lit content on LinkedIn lately. And his post yesterday about the audit limitations of health plans kind of broke my brain. I thought I'd dive deep today on health plan audits, what could be a big advantage for some and really scary as hell for others. But as always, the issue is more complicated for all the parties. Most employers with hundreds of thousands of claims per year, they audit 300, maybe 400 once a year. That's it. There's actual research showing that approach misses over 90% of errors. Not sure it's that high, but that's what the research shows. We're talking hundreds of thousands of dollars, if not millions, in overpayments for employers just gone. And here's the part that's wild. Providers are now running AI to find every single underpayment, continuous, automated. I had a health plan CEO recently just tell me that they found over millions and millions of dollars of claims, and they're actually going directly to lawsuit. They're not even going to try to convince the payer to pay it. So payers are running AI to deny more claims at scale as well. And all this sounds like this could be just one big AI mess, and it actually could. There's literally the only party in healthcare ecosystem today that's not running continuous AI on their own dollars. Let's do that again. Employers are literally the only party in the healthcare ecosystem not running continuous AI on their own dollars today at scale. And today, I want to show you what's actually happening and an architecture that could change everything. So let's jump over to that post and let me show you what I'm talking about. So this is the post that Mark Cuban put on LinkedIn yesterday. And I'm going to go through it with you and give you my thoughts. So he writes, a reminder to self-insured CEOs. If you sign an ASO agreement without full audit rights, you made a bad mistake. If you don't go immediately ask for all of your claims and demand an immediate audit, you might as well go to the bank, grab a few $1 million in cash, walk to the middle of the street, and burn it. Your cost to do an audit is in the thousands. Your benefit is probably in the millions. What competent CEO wouldn't spend thousands to get reimbursed a multiple of that amount? I have never heard of a company that did an audit and found out they were paid the right amount or too much. Never. There's a lot of truth in this statement, but let me walk you through a few things, and I'm going to show you how complicated this can get and why it's not as easy as he talks about to get this pulled off. I'm going to show you some actual contracts so you'll get to see what I'm talking about. First of all, is this true? Well, I actually went on and posted that the overwhelming vast majority of companies do not have audit rights for insurance companies built into the ASO contracts. Now, I took a little grief from that. Several people wrote me direct messages and said, Dan, that's not true. I've never seen that. Well, what I'm going to show you is that they may have provisions that allow for audits, but the provisions don't allow for very much. And I'm going to show you an actual contract so you can see sort of what I'm talking about. And even if they do allow for an audit to occur, it's often very limited as far as that audit is concerned. Second of all, let's go back up to his post here and take another look. He says, you might as well go to the bank, grab a few millions in cash, and walk in the middle of the street and burn it. An audit costs in the thousands, your benefits probably in the millions. Well, that's not necessarily true historically, but he's true today. And I'm going to show you a few reasons why I think that this is very progressive in the way he's talking about it. Historically, one of the reasons that audits weren't a huge provision within a contract is because they were hard. It's really hard to do a claims audit. So the idea that you could audit millions and millions of claims at scale was just a very difficult thing to do. Human audits are really expensive. So if you paid someone to look over every claim that came through and you added up the cost of doing that, just really wouldn't make sense for most employers. That's one of the reasons that most employers actually didn't go down that route and why they never really pushed back or fought back on that provision. So that's something to sort of think about. Let's go through some of these other comments on the post. See if there's anything else we might want to focus on. Here's one. Audit rights aren't adversarial. They're basic fiduciary discipline. Any CEO comfortable self-insuring without transparency, accepting asymmetric risk by choice. Well, that may be true, but I think one of the things you find today is that many employers probably don't have a choice. They're not given an option by the health plan to actually modify these contract provisions. Now, it's true, you could push back, but there's not a lot of insurance companies. And when you start to look at the value that you could get in network discounts or in the contracted rates, it's not as easy just to say, well, I'm just gonna walk away. Since you want that provision in your contract, I'm gonna walk to a different health plan because there's a pretty good likelihood you're going to find a similar level of contract language in another health plan as well. So it's not as easy as negotiating that out for the employers. It's one thing to think about. Let's keep going on down through here. Um, Pharmacy audits are and PBM audits are kind of a little bit of a different animal. I'm going to address a little bit about that today as well. But lots of comments on this post, and I think it's worth diving in and actually seeing exactly what Mark is talking about because I think he's onto something. And I think we're kind of in a world today where this kind of information is going to be really important at helping to solve healthcare costs because transparency is one thing. But if we can't figure out a way to look at the transparency of these contracts and what is actually going on, then we can't get to the level of actually solving healthcare cost problems. Now, the one thing I'm going to tell you up front, I'm going to show you kind of a bad story here because the biggest risk that I see with modifying this language today, and I think it does need to be changed. I do think that employers need to have a better idea, better ability to audit claims. But one of the things that to be careful with is the idea of asymmetric audits. And I'm going to walk you through a little bit of an example later that should really be scary. So hang on and we'll get to that in just a little bit. So let me actually look at an actual contract. So this is an actual contract that I'm going to go through with you showing a typical kind of audit provision in the contract. So this is one that I found online. So this isn't something that I had. I found it online, but let me just kind of read it to you. Employer audits claim administrator during the term of this agreement and within 180 days after its termination. So right off the bat, it's limited, right? You're going to have to be able to exercise this particular clause really soon after this actual contract is terminated. An employer, an authorized agent of the employer, subject to the administrator's reasonable approval. So what that means is actually a very interesting clause that basically says that you actually have to do the audit yourself, or we have to agree for a third party to do that audit with you or for you. This is important because this means that if an employer hires a consultant, hires a broker, hires a firm to actually do the audit, it's got to be approved by the carrier. Now, I think that's a provision, to be honest with you, that should not be included in there because I think that an employer ought to be able to hire whoever they want to do an audit. But it is something that's kind of buried inside parentheses, but I actually think it's pretty important. May, upon at least 90 days prior notice to the claim administrator, conduct reasonable audits of records related to claims payments to verify that the claims administrator administration of the covered healthcare benefits is performed according to the terms of this agreement. Now, that's both a pretty broad statement and a pretty focused statement. Basically, what you're auditing is the claim administrator actually exercising the provisions of the contract correctly, meaning are they paying what they should pay and not paying what they should pay. So this is typically what a claims audit is. Contingency fee payment audits are not supported by the claims administrator. Okay. Now, for many of the providers out there, including the docs, and back in the day, I can tell you that I actually helped a practice many years ago have to deal with this with Medicare. Many of the RAC audits, the recovery audit contractors that work for Medicare, they work on contingency, meaning that they will audit a provider's claims history or claims payment system, and they'll actually do it on a contingency plan. Now, we can argue all day long about whether or not that's a good idea or not, but the take-home message here is they're not going to support any kind of third party helping an employer to do a contingency audit. So that's very important here in the contract. Audit samples will be limited to no more than 300 claims. Now, this is one contract out of literally thousands, if not hundreds of thousands of contracts that are signed every year by employers with health insurance plans. But I'm going to tell you that's pretty typical. It's almost always a sample of claims. It's never going to be like a total claims audit. It's usually not thousands. It's usually in the 300s and range. And I'm going to tell you in a minute that that's probably not enough claims to be audited. But because of the cost of doing these audits, that's typically the reason that it occurred. If a pattern of errors is identified in an audit sample, the claims administrator shall also identify claims with the same errors and will reprocess such in the identified claims in accordance with the claim administrator policies and procedures. So basically, what they're going to say is that if they identify claims within that audit, say for instance that every time a certain knee replacement surgery came in, it was incorrectly adjudicated according to medical policy and paid incorrectly, or paid at the wrong rate, or paid on the wrong fee schedule, then they'll go back and reprocess all the claims for that specific procedure throughout for the rest of the health plan. But you can already tell this is going to be pretty limited. It's going to be limited to the 300 claims that you actually audit. So it could be a big deal if they made big mistakes in a certain procedure along the path, right? But it also could be very limited because you're not going to get a lot of reprocessing or relooking. It's not like an audit where if we find a group of problems, we think, oh my goodness, I'm going to dig a lot deeper. That doesn't really happen here. It's a very limited and sort of controlled audit. So that's something to think about. Notwithstanding anything in this agreement to the contrary, in no event will the claims administrator be obligated to reprocess claims or reimburse the employer for alleged errors based on audit sample extrapolation methodologies or inferred errors in the populations of claims payment. Now, again, back to RAC audits and what happens in Medicare, you're going to find that that's not the way it works over there. Extrapolation is exactly the way it works, meaning that if you find a certain set of errors in the way knee replacements are paid, very well could be that that could be the same way that hip replacements are paid, wrist joint risks are paid, etc. So that basically says you can't do extrapolation. And this really ring fences the findings of the audit to those particular CPT codes, for instance, that are part of that actual 200 or 300 claim adjudication. All such audits shall be subject to the claim administrator and the current audit policy and procedures. Now, I'm going to stop there and just say that basically there's another set of documents that basically says this is how we work with claims audits. So not only are you going to be ring fenced by the provisional language here around those individual audits, but you're also going to be ring fenced a little bit about how you see generally one of these firms, the health insurance companies, actually deal with audits in general. What are their actual rules, related to the audit? And the audit period shall be limited to the current agreement year and the immediately preceding agreement year. No more than one audit shall be conducted during a 12-month period, except as required by state or federal agency or regulation. So basically, you get one shot at this. You have to do it. You have to file for it almost within 6 months of when you finish the plan year, and it has to be limited to that specific year in question. 200 to 300 claims, despite the maybe hundreds of thousands of claims that you could have actually filed. Not going to go through any more here, but that's the basic gist of what one of these audits actually looks like inside of a contract. Now, the problem is that this is an article, it's pretty dated. It goes back to about 2010, but this article basically said that the average medical claims error rate typically ranges from 2% to 5% of total claims paid. So if you think about the error rate being 2 to 5% on any kind of business that you were working on today, that would be just unheard of. And so the idea that you would have to look at only 200 or 300 claims, you couldn't extrapolate it. So let's say, for instance, that you did this and you found an error rate of 5% in the 200 claims and you can't extrapolate it, then we're talking hundreds of millions of dollars here that are really not subject to a traditional audit in a given contract like the one that I just reviewed. So a pretty big deal here to not have access to be able to do these audits. Now, again, Mark said, but you could, don't sign these agreements, but many employers really just don't have that luxury. I mean, they're looking at the long ball here, which is that I'm working with an insurance company that has great network pricing. Because of that, I have to sign the contract. So it's almost like employers don't really have a lot of luxury in modifying these contracts. I'm not going to say that they never do, but it's not as easy as that. Now, I've talked specifically here about claims audits But just for the other people that are kind of like new to healthcare, I mean, we're in through a couple of other types of audits. There's risk assessment audits, which actually look for risk. We're specifically kind of talking today about claims audits. There's also kind of an electronic claims review process, looking at the systems that you have in place that actually look at it like electronic claims. There's operational review. You can actually do a focused claims audit. And I've actually seen this pretty commonly. That's where an employer is thinking, like, you're not paying dialysis claims correctly. So it's really focused just on dialysis. Sometimes it falls within that agreement. Sometimes it's something that the health plan and the actual employer would just actually work out together. And that would be a focus claims audit. Many times that's a mutual thing because the health plan at the end of the day doesn't want to be paying claims incorrectly. So they want to be paying claims correctly. In a self funded insurance contract, there's really no benefit to a health plan paying the claim incorrectly. What it does do is that it can fix some administrative errors, some processing errors that could have occurred within it. There's a statistical claims audit, and you notice those were not included in that language. A statistical claims audit is basically where you just look and say, this percentage of the time, this is the way something should occur within a payment system. Medicare was historically kind of good at that. That's how you ended up on a red flag list because you maybe were billing too many 99213s or 99214s. And so you would end up in a statistical claim audit. But that's not really applicable here because the provisions don't really allow for it. Manufacturer rebate audit, these are becoming a little bit more frequent. And this is where you audit basically the PBM's ability to make the rebates. Now, I think this is incredibly complicated, and I'm going to do a video in the future about how these rebates actually work and how it's very complicated for employers to actually play a role here, and how, because it's difficult to understand, it's even more difficult to actually audit. There's a compliance audit, just looking for compliance with policies and procedures. And then finally, an eligibility audit. This is something that's often done on the employer side, basically just to say, hey, are these employees actually employed by the company? Now, one of the things I think we've really kind of dug in here, the fact is that should you be doing 100% of claims versus random sample audits? Because basically, when you're doing 200 claims, you're basically doing a random sample audit. You're just picking something. Now, in practice, it's usually not random because in practice, usually what happens is you will look, if you're an employer, you usually get to play a role on what procedures and what things are actually going to be audited. And almost always it's going to be things that are costing you a lot of money or things that are running out of the, compared to history, they're not matching up with previous years. So it's usually not random, but it's certainly not 100% of claims. And so way back, this is a study that was done back in 2011. The objective of the study was to examine the relative efficiency of two different methodologies for auditing self-funded medical claim expenses, 100% of claims auditing versus random sampling. Multiple data sets of claims errors or exception from two Fortune 100 corporations were analyzed. So these are big companies, and they actually did this study to see, okay, would random sampling work? Compared to 100 simulated audits of 300 or 400 claim random samples. So this is exactly in the wheelhouse we're talking about today, which means that will 300 and 400 claim samples actually work in an audit, or should you be auditing all of the claims actually within the system? So random sample simulations fail to identify a significant number, and the amount of errors range from $200,000 to $750,000. Now, this is in 2011. I'm going to tell you, healthcare prices have gone up a lot since that time. So my gut feeling is, assuming that these results are applicable, and I think they actually are, you're going to see a lot more a cost today difference between that kind of study of just doing a random sample versus auditing all of the claims that could be going on within the plan. So this basically proves what we've been talking about, is that random samples don't really work. And that's actually what's been codified in most of the contracts that employers are actually forced to sign today. Now, this is was a really cool article. It's from this group called Smart Light Desk News. It was published in 2023. And I just want to go through a couple things here because it's kind of relevant to our conversation. So large employers with self-funded health insurance plans typically have post-payment audits of their healthcare services as part of their ASO agreement. So again, back to my hyperbole and my response to Mark Cuban, they usually do have them. They usually do have an agreement. These audits seek to review claims for payment integrity. So let's talk a minute about payment integrity because that's a buzzword. I think it's sort of falling out of favor. It was a nice way of saying fraud, waste, and abuse. So people moved away from fraud, waste, and abuse and started to call it payment integrity. And many health systems put in place ways to help to detect payment integrity or fraud, waste, and abuse. Many of times these were algorithm-based systems that would look for outliers. They would flag it often to a human reviewer who would step in and say, wait a minute, this was billed wrong. This claim was duplicated. This claim was actually a knee replacement, but it got billed as a hip replacement, things of that nature. They were called payment integrity. These audits seek to review claims for payment integrity. However, audits are generally done infrequently on a small sample size, just skimming the surface. Okay, we've seen that. In comparison, ongoing monitoring offers employers a continual review of all claims. Okay, so I think that's where you can see I'm going, is that if the random samples don't work, then maybe what we need to do is we need to review every claim from an employer standpoint. Because if you review every claim and theoretically the review process has had the right validation, the right rules, the right algorithm, the right oversight, then theoretically you wouldn't even need to do an audit, right? Because you would have the ability to do this in real time. And the audits then would be basically audits of your systems. Those would become system audits, which is why I showed you that before. According to recent statistics, 65% of employers offering health insurance have self-insured plans. That's probably true. In the US today, nearly all employers with 1,000 more health insurance workers offer health insurance, which means monitoring spending on healthcare is increasingly important. Okay, this just kind of codifies what we talked about. In many ASO agreements, the annual audit outline will take a small random sample. This represents a tiny subset of claims and can limit what is revealed by the audit. This is especially true if the audit uses analytic models based on known issues within claims. So what that means is the fact that many times these audits kind of go down the same path, meaning that it's always the same sort of thing. So they're just sort of copying the playbook from last time and building the playbook this time. I don't. The other reason I don't really like that approach is that many times an audit should be self-improvement. You do an audit, and you should, as a payer, you should actually relish an audit because you want to pay claims correctly. So having all of your claims audited should be something that a health plan actually wants to do. Now, in practice, I think they probably don't want to do it because of the work. That's the big one. But the second part of it is that I believe there's a lot of problems that need to be fixed. And so if you were to start to audit every single claim that came through, you would find a lot of problems. And if you found a lot of problems, that could require a lot of fixes. A little bit of background, many of the claim systems today of all of the big insurance companies, I'm not going to mention their names, but you know who they are. These systems are coded in systems that are very expensive to change. They're not easy to change. They've been around for decades. They're often written in languages that aren't even taught in college anymore. And so actually going in and making these fixes within that code to make that fix, it's expensive. It's actually really hard to do, by the way. And there often isn't great documentation on figuring it out. So I can understand a little bit of the hesitancy from the employer standpoint. Excuse me. I can understand a little bit of hesitancy from the payer's point of view, because this could reveal a lot of things that need to be improved and changed. But until we do that, it's very unlikely that you're going to be able to get the problem fixed. So conversely, an ongoing monitoring approach digs deeper and can reveal more useful data for self-funded employers. Most significantly, ongoing monitoring analyzes 100% of claims data continually, and they customize based on each employer's population to look within the claims data for potential issues. Now, I tend to agree that this is a good approach. There are some challenges. One challenge we already saw, and it was mentioned in one of the posts in one of the responses in Mark's original post on LinkedIn, is that employers often don't have access to all of this data, all this information. So not having access to it makes it hard to implement these types of systems. And we already saw that there could be resistance on behalf of the payer to do it because it could result in a lot of things that need to be changed. But I think the goal here is that ongoing monitoring is generally the way to go. And I think we're getting to a point today where artificial intelligence systems are going to offer a big advantage to doing this continuous monitoring. And I'm going to show you a few kind of examples about this today so that you'll kind of see what I'm talking about. Okay. So before we go into talking about AI, I want to talk a little bit about algorithms. So many of the payment integrity systems that have been put in place today, they were algorithm based, meaning that if you fell out of a window on charges, or if you fell out of a window on claims, for instance, and you were on the ends of the bell curve, that could be flagged. Often it could be flagged for an auto adjudicated fix, meaning denied. And there's been lots of stories in the news about insurance companies sort of putting in place systems that would just deny things more frequently. So that's out there. But we're really kind of getting to a point today, and this is an article back from 2024, which really starts to talk about the use of large language models and AI systems to actually do this work. So it's not specifically algorithmic anymore, it's generative intelligence that's actually doing it. And I'm going to show you some of the things that have empowered this to happen. But obviously, the ability to have AI systems sitting on top of your claim system and looking and analyzing those claims is actually one of the reasons that I think the systems can actually work. So, healthcare fraud, waste, and abuse are costly problems. They have huge impact on society. Traditional approaches to identify non-compliant claims, relying on audit strategies requiring trained professionals, or on machine learning methods requiring labeled data and possibly lacking interpretability. So what basically we're talking about here is that in the past, one of the reasons that these contract provisions, which are stale, that talk about 200 and 300 claims, is because you really had to have humans. You had to have humans look at the claims. If you've ever looked at a hospital bill that actually comes in, a claim for a procedure, all of the DRGs, all of the added costs that are added in there, the provisions related to stop loss, it's complicated. So the idea that you could do this with a simple algorithm was just impossible most of the time. Most of those algorithms are actually already built into the claim systems within the payer. So you're not going to find a lot of low-hanging fruit auditing things that already have an algorithm. So it typically required you to have people put in place, or payment integrity, fraud, waste, and abuse, people that were actually trained to actually look at these individual claims. And then maybe some machine learning systems, meaning fancy algorithms that would do a little bit of work, which started several years ago. But this system starts to introduce the idea that you could actually introduce AI systems that are overlooking this machine learning to actually give you a better result. And so let me talk a little bit about where I see the current state in AI and claims operations. So about a year ago, and obviously in February a year ago, I spoke at a big, large insurance conference, and I spoke on AI, and I talked a little bit about what I see in the future, where I think the risks are, what I think is happening in the AI world. And one of the things that I told the group then is that of all the different groups or the stakeholders in healthcare today, whether it's the employers, the payers, the providers, which we'll call the doctors in the hospitals and the PBMs, the group that is having the fastest uptake in AI systems has to be the hospitals and the physicians. They have readily adopted AI automations into their workflows. To me, much faster than the actual health plans, and certainly faster than what I'm seeing in the employers. And one of the things that you're seeing as far as AI and claims operations has to do with prior authorization and appeals. And it just makes sense, right? If you see a patient in your office and you know that this patient needs a knee replacement, but you've got to get a prior authorization, well, man, it'd be real simple. Just drop that note into a HIPAA compliant system. Let AI adjudicate whether or not you've met all the criteria according to the medical policy for a health plan, help you draft your prior authorization request, and optimize it so it's perfect, and let it go off to the health plan to get approved. It just makes sense to actually do that. One of the warnings that I gave the health plans last year is that I saw such uptake in these kinds of systems, which started with ambient listening in the waiting room, now progressing into these prior authorization systems, But the health plans needed to be prepared for that. They needed to be able to be prepared. I mean, you might say, well, prepared, these are perfect. No, they're not perfect. And we all know that, that there's things called AI slop. There's things where AI can actually hallucinate. AI doesn't get it right all the time, but it does really kind of talk about the fact that you need AI systems on the health plan side and you need AI systems in the provider side that can actually talk to each other. You need to start to develop a framework and an architecture where you can have agent to agent adjudication of issues. Otherwise, what's going to end up happening is that these prior authorization requests are going to come in from the providers. They're going to be perfect and they're going to hit a retired pediatrician working part time at a health plan going through these and looking for changes in medical policy. It's going to rapidly overwhelm an archaic system. And since many of the health plans don't have AI systems that can adjudicate and do this intentionally, you're going to find yourself in a really big mismatch. I said this almost a year ago. And in the last year, I have seen a little bit of growth in AI systems within the health plans, but not a lot. So, one of the things that I think we have to be really kind of concerned here is starting to see the imbalance that can occur here. The imbalance about whether or not you could find one system that could use AI, which could be really fantastic at going through all of your claims. Remember, 100% of claims, and then bouncing it up against a system that's still living in 1990s technology. And I think that's really something that we really have to be worried about. So I want to talk a little bit about where I think we are today and why I think this is a very relevant topic and why those contract provisions need to be changed and what we as benefit consultants and also as employers and as payers all need to be thinking about in this world of AI. And it has to do with the fact that we now can build agentic systems or AI systems that really can run on all of these claims at the same time and almost run autonomously. And I'm going to show you a little bit about what I mean by that in a minute. These systems will basically take AI architecture, self learning, reinforcement learning from human feedback, what's worked in the past, and you actually look at a group of claims and actually get better through self learning and self annealing over time to actually give better results within an audit. And since it's automated, there's no human cost involved. Once you actually build it, the cost of actually using these systems is a lot lower. And remember, I told you one of the limitations on that 200 or 300 claim rule really was the fact that it was so expensive. Well, here you've got a tremendous advantage of actually lowering the cost through agentic systems. So I do think we're moving into a system. This article is dated in April of 2025. I think we've made a lot of progress in the last 6 months. I'll show you a couple of examples here in a minute, where in reality, this is actually should be mainstream today, meaning we should be able to analyze claims at scale and then adjudicate them through a health plan audit. I know we can do it on one side. I'm not sure we can do it on all of the sides. And if we can do that, then we have the ability to do ongoing monitoring, which is this approach of actually, as we submit a claim, we can actually do this ongoing monitoring that we talked about before, that we're not doing a sample, meaning that every claim that gets submitted actually gets audited and is correct and perfect before it actually gets paid. Now, think about that as a patient, for instance. If we could do this at scale, it would benefit theoretically everyone. We would be paying for what we're supposed to be paying for. Patients would get their procedures paid for, so they wouldn't continue to get bills from the provider or the doctors in the hospitals long after because the health plan is either waiting to pay it or it's stuck in a system. And theoretically, it would cut down on the waste and the fraud, waste, and abuse in the system. This could have a big impact on the overall value of healthcare costs. So, something that I think is really important. And I think the problem I'm seeing right now, and I'm going to kind of show you some examples, is that I think that we're starting to see a mismatch because we're in the adolescence of this system, meaning that we're starting to see systems that are actually growing up in these different stakeholder groups disproportionately. I think we have the concern here is that you could find opportunities, at least, for people to be kind of weaponized to either deny a claim or to overcode, do all kinds of things related to these particular systems. And I thought it would be good for me to give you just a global look at how complicated this is. And then maybe together we can explore maybe what are some options or some opportunities for challenges. Okay, so let me show you a little diagram that I put together. So this is the contractual relationships that occur within these healthcare systems. So when we talk about the contract that Mark referred to in that post, that's a contract between the self-funded employer and the TPA administrator. So that contract that we reviewed is this contract right here, which is limited to the 2 or 300 claims. And that usually is with a TPA administrator. Now, we often refer to that as being the insurance company, but there's very little insurance going on here unless it's stop loss. Typically, in this case, the insurance company is functioning more like a bank. They're just a transactional employee, and they are doing transactions on these medical claims against a medical policy, and they're basically paying the providers, the doctors, hospitals, pharmaceuticals companies, and all that. And then they're charging the self-funded company back the payments for their healthcare. So they're really just sort of running as a transactional agent, which is why, if you think about it in a pure sense, they actually should want to do the payment perfectly, right? Because there's really no advantage to paying claims disproportionately here. Now, this TPA administrator is going to have two broad sets of contracts, and I kind of separated them out. They're going to have contracts with point solution vendors. These are people that are doing services on behalf of the health plan already. Now, back in the day, like 20 years ago, almost all of the services that were provided to a self-funded employer were done by the TPA or the insurance company. That could have been healthcare management, behavioral health management, all kinds of care management, case rate, utilization review. All of that was done entirely by the health plan. But one of the things I've observed, particularly in the last 5 years, has been the fact that the innovation level within American health insurance companies, it's actually really gone down. And there's been a great leaning on point solution vendors, and there's 5,000 or 6,000 of these now that actually will plug into the health plan or plug into the employer, and they've taken over a piece of this actual work. Now, there's almost always a charge involved, which means that they play a role, many of them do, in the actual claims payment solution area. So that contract is going to be held by the TPA administrator. So now all of a sudden, the insurance company's got to worry a little bit. Okay, is the point solution vendor performing on behalf of the employer well? And then the employer really needs to worry, because if this contract is held by the TPA administrator, can you see the disconnect that occurs here between the employer all the way over to the point solution vendor? Are they actually doing things as they should? So that creates already some opaqueness. And then also I put PBMs up here. And the reason I think this is really complicated is because many of the large insurance companies actually have financial agreements with the PBMs, actually own the PBM. That's true with point solutions too, to some degree, but it's really, really more common in PBM. So you can start to see that same opaqueness and complexity that you're seeing here is actually going to occur even to a greater extent with PBMs. But probably what I want to focus on mostly is the fact that this TPA administrator is going to have contracts with the providers, and that's the hospitals, the doctors, and the pharmacies. Now, and remember how this works, right? The self-funded employer contracts with a TPA administrator, and with that, they're responsible for adjudicating a claim, and meaning paying a claim according to medical policy, and then paying a rate that's been pre-negotiated with the provider, right? So basically, there is an obligation, a fiduciary obligation here, that the TPA administrator will do that work on behalf of the self-funded employer and actually do that work correctly. And that's what we're talking about on the claims audit. But another contract exists as well. And that contract exists between this TPA administrator and the provider, or the hospital contract, the doctor contract, the pharmacy contract. So not only do they have to adjudicate the claim and pay it correctly here, but they have to pay the hospital correctly. They have to pay the doctor correctly. They have to pay the pharmacy correctly, which means that theoretically, there is an audit risk on this direction too. And this, to me, is where I see the biggest risk going on today. And the risk is that the systems that are occurring to actually audit these claims between the hospitals and the doctors, but particularly the hospitals, these are very sophisticated systems. And you're starting to hear stories on the street that hospitals are bringing in companies that are actually auditing all of the claims on the hospital side. And they're saying, wait a minute, we've got, $100 million worth of claims that weren't paid correctly, meaning that there were claims errors. And I've even heard stories that hospitals are even bypassing the normal contractual arrangements, and they're basically just going directly to a lawsuit, meaning that we're just going to sue them on behalf and then work out some sort of settlement related to this amount of money. So this is something that I think is a big concern, is that this process is happening, I think, at an accelerated pace. This system up here of being able to do this themselves, adjudicate the claims themselves so that they're not having to rely on these third-party lawsuits and third-party systems. I don't think that's happening very fast on the health plan side, or if at least it is, I haven't seen a lot of it. And on the employer side, because of the lack of the ability for data, because of the provisions in the contracts that limit audits, it really puts the self-funded employer at a huge disadvantage in this particular system. So I'm concerned that one of the big mismatches that can happen is that if hospitals and doctors are really accelerating these systems and they're able to be successful, maybe appropriately so, by the way, but successful in basically recalculating the charges and the payments from this TPA administrator, then you may find a significant amount of increased costs now occurring, right? Because we're now administering claims correctly on the provider side, not arguing that that shouldn't be done, but we're administrating them correctly here, but we're not administering them correctly here. And so not doing the same level of auditing on both the consumer and the payer side of this could be a significant problem in the short term, which is why I'm really encouraging including agentic systems as fast as possible in all of these boxes. You don't want just the providers to be using agentic systems to do auditing, because if you did, you would find yourself in a situation where there's a huge mismatch in payments, a lot of additional charges that the TPA is responsible for, but not a lot of the different fraud, waste, and abuse that was picked up on payment integrity. So payment integrity systems and adequate claims payment on the provider side all need to happen at the same time. And we need to see agentic systems that can be able to adjudicate and make sure that it matches and that we've reconciled those differences well. Otherwise, I think this could be a significant problem. Now, I couldn't leave this talk with actually talking about one thing which I think is readily apparent today, and that has to do with the fact of doing why is this possible today? And I think that we're far beyond. Let me start over. I can't leave today without saying why is this possible? I think it's possible today because these systems are in place today. Let me start over. Why I'm having this talk today is because I think we're now in a position where there's incredible opportunity for us to do this automation at scale. And it has to do with something that's occurring in AI. And I want to introduce a word for many of you that aren't really versed in the AI world today because it's so rapidly changing, it's hard to keep up. But it's called AI harnesses. Now, AI harnesses was a concept that was actually introduced by Anthropic. Anthropic is the large language model Claude, which is kind of a competitor to ChatGPT, which is often a little bit well known. But they basically released this really interesting article back in November about using harnesses for long-running agents. Basically, not just running a large language model that could actually loop over a Google sheet, but something that could almost run continuously or run over big, deep projects. And let me explain a little bit about why I think this is really applicable to the conversation today. If these systems can run continuously and every claim could go through it, then we could have the audit experience occurring at the time, near the time, or even before a claim is actually paid. So we get to a system that is approaching way more perfection than what we saw in the data before, where as much as 5 to 10% of the claims could be error. What if we could get the error rate down to like 0.1% or something like that with an AI system? So that's the first component where I think these systems could offer a pretty significant improvement. The second thing has to do with the fact that these systems can run continuously and deep, meaning that they can really go through your claim file. So, for example, many of the claims today are not simple, they're extremely complicated. There are the children's hospital claims, which can be children can be in the hospital for extended period of time in the NICU. These bills can be extremely large. The amount of records can be extremely large. Being able to go through all of that information in a very deep manner is very, very, very complicated. And one of the reasons, again, that we're claims audits are kind of limited before. These systems, because they can be long running, they can really go deep into the adjudication and the understanding and the reconciliation of those claims. And you can get incredible, incredible results. Let me just show you something really quick here. So this is inside my VS Code. This is something inside of Rocket Tools that we've actually built. And we actually built one of these. So just to show you that this is not beyond the realm of possibility, this took, I think, a couple of days to actually for us to put together. And we now have systems that actually can run continuously on a problem. So we had a client that actually reached out to us and basically asked us to build a system that would allow them to create YouTube videos about their project. And they wanted a complete system where they could log in and have a user interface and a website. It would go out and do research. In other words, they wanted a full, complete software package that would help them tell their story around their problem. This was a healthcare point solution. In the old days, we would have had to go find them software, subscribe to it, teach them how to use it, and then adapt our recommendations were to their software. But today we don't have to do that. Today we actually can build them their own software for their own problem. And we can do that not in a piecemeal manner where we're putting a vibe coder or somebody in front of a system. We can actually develop a project requirements document and then turn an AI system loose to actually go do it. So why is this applicable to healthcare audits? Because now we could actually do an audit plan on a big group of claims, and we could turn an AI system loose to say, hey, build me a system that will evaluate these highly complex claims and come back to me with recommendations for the amount of money that I either owe or don't owe, and how I would actually fix the system in the future so it wouldn't happen again. Those systems are actually available today. And I think that is going to get us to the point where we're going to have the ability to audit 100% of health claim cost. And I think this is actually the system, this is actually the approach that we need to get to affect and answer Mark's question. It's not really a matter of actually changing the contract provisions. We need to get rid of those contract provisions, and we need to be going to a place where we have continuous AI automation of auditing. And if we do that, we can automate in real time, which means patients get their bills paid on time, providers get paid on time, and employers get those claims paid accurately on behalf of their employers. So I hope you enjoyed this live stream. We are going to repurpose it for YouTube. Thanks for joining me. And if you have any questions or any comments, be sure to leave them in the comment section below.